I am Dr. Inderpal Singh, a consultant dietitian and a national clinical lead for bone health in Wales. In the last 4 years, Aneurin and Bevan Fracture Laser Service have identified more fragility fracture patients, which mean from 23% patients, which is just 800 patients, we have grown to 80% patient, which is 3,000 in 2025. Now, we know that NHS has got outpatient travel, which creates about 20% of healthcare carbon emission. However, fracture laser services is primarily outpatient services. So we have to redesign our care pathways. We introduce all patients are reviewed virtually first, followed by nurse-led telephone assessment, and then working in partnership with the GP and community. And finally, one-stop clinic for specialized treatment. Over 3 years, we reviewed 2,700 patients, and this avoided 25,000 miles of travel, cutting nearly 10 tons of carbon with our initiatives. This shows high quality care can be delivered, can be efficient, accessible, and genuinely carbon negative. Within NHS, outpatient care typically accounts around 20% of overall carbon footprint. Our fracture laser services are primarily outpatient services, and yet demand is rising sharply. Over the last 4 years, we have increasingly identified fragility fractures using radiology reports, which means we have increased our identification rate from 23%, which was only 800 patients in 2021, to 80%, which is 3,000 in 2025. This is double the national benchmark. To meet this rising demand and honor ministerial commitment in Wales, maintaining clinical excellence, we needed pathways that were prudent, effective, and efficient. To address the challenge of increasing fragility fracture patient identifications, our FLS team undertook a structured, multi-phase quality improvement journey and redesigned pathways step by step. Firstly, we introduced virtual first review. Every new fracture patient we identified using radiology report was reviewed remotely by our FLS coordinator to confirm eligibility and direct them to the most appropriate pathway, as we can review them during inpatient stay, outpatient, or even community managed. Now, these triage improved efficiencies and avoided unnecessary hospital attendance. The next step was patient received comprehensive telephone assessment from our bone health nurse. These consultations covered risk assessment, explaining the diagnosis to the patient, and planning their treatment with patients, and then offering DEXA if needed. This means the patient never needed to attend a clinic at all on occasions. Thirdly, we strengthened our partnership with the community teams and GP. Patients need blood test, they need some prescribing, they go to the GPs and get that whole layer of patient travel removed and improving continuity of care with GPs. Finally, those patients who need specialist treatment, we introduce streamlined one-stop clinic. In this clinic, they get full assessment for their osteoporosis, get education, and if they need injections or infusions, were also delivered in a single visit, eliminating any repeat appointments or travel. We are working in partnership with NHS Wales and Bevan Commission so that the good practice can be spread and shared across whole Wales. Now, these pathways are being in practice in Wales, and we are supporting the delivery of Welsh Government's quality statement on osteoporosis and bone health. Overall, this was an elegant, patient-centered design, saving time, reducing travel and emissions, but ensuring patients continue to receive high-quality osteoporosis care, what they need, what they deserve. Our intervention delivered benefits across patients, environment, and the health system. We analyzed travel for 2,700 patients over 3 years, which was only for the first consultation. We noted 87,000 miles would have been expected for these journeys. By redesigning the service, we avoided more than 56,000 miles through telemedicine, GP-led management, and shared decision-making with our patients. While in some person visits will remain essential, for treatment like denosumab, zoledronate, or anabolic specialist clinics, we encourage that. Overall, we achieved a net reduction of almost 25,000 miles over 3 years. This is equivalent to 10 tons of carbon avoided, making the service truly carbon negative. For patient, this meant fewer unnecessary journey, less time off work, and care closer to home. But economically, it reduced travel costs for patient, improved clinical efficiency, and allowed us to meet the rising demand without expanding that physical capacity, demonstrating high-quality, sustainable care that works for people, the planet, and our NHS. I'm just sharing my opinion. Sustainability doesn't require radical change. It starts with small, clear clinical decisions. We need to question ourselves, does our patient need a face-to-face appointment? Can we optimize this investigation in primary care? Can we work more closely with community multidisciplinary teams? Care designed around patient needs often improve quality, reduce waste, and should be seen as part of good clinical practice, but not as an added burden. I encourage everyone to continue working in partnership with patients and strengthen collaboration with key stakeholders. Often, what's good for our patient is best for our planet too. Thank you. I'm very grateful to the Royal College of Physicians for giving this opportunity for us to share this story from Wales, and I'm truly grateful to the college for introducing the Green Physician Toolkit. I believe this Green Physician Toolkit will be adopted by many teams across the world. Thank you.